Welcome and thank you for joining us today. And we're going to do, as we usually do, a webinar program in two parts. Let me just move my thing. There we go. One will be data, and the other one, which is really focused on, of course, what's the relevant information about what's going on in Hudson Valley nursing homes. And then the second part will focus on resident rights, and this is one that, program we've done in other areas before that has been really popular, which is what to do when things go wrong in your facility. A little bit about LTCCC. We are, of course, a nonprofit, nonpartisan organization. We focus on policy research and analysis, data research and analysis to identify, trends and issues in nursing homes and assisted living, and how they can be resolved. And more over the years, we have been doing education of residents and their families, long-term care ombudsmen, and other stakeholders to help them in their efforts to improve nursing home care. And we're also the proud home of two local long-term care ombudsman programs here in the Hudson Valley. And I'm Janine. Janine, thank you for. I hope I admitted Janine. Oh, there she is. Hey, Janine. Nice to see you. It's been a long time. Thanks for joining. Oh,
Of course.
and we have. I don't know if it's the holidays or what, but we're starting off slow in terms of attendance.
Yes.
Although, as with everything, these programs are recorded and people are viewing them. So I'm happy to see that. And we're just getting started. So thank you, Janine, Donna, and Jane for joining us and moving right along. Helping us with these programs is John Rodat, who's just an incredible expert in terms of nursing home and other data in New York and beyond. So as I mentioned, we're going to start with a data briefing of what's going on in nursing homes in, oh, here's Linky. I'm glad she came on before and then she was gone. Hi, welcome. Um, and what's going on in, with some focused data points on Hudson Valley nursing homes. And then a program that we have done before, actually, we did with Janine on tips for addressing challenges and problems, which was like one of our most popular programs ever. We got like thousands of people that watch, if I remember correctly, that watched that program. So I was really excited about doing it here and glad that it'll be recorded. I don't know why I keep on. There we go. Okay, so we're going to start with the update. Just a little bit about why data are important. I know people's eyes fog over. Mine did for many years. As I've told people, I got a D in statistics in college. But we do a lot of data work here at the coalition. And the reason for that is because data are really important in supporting advocacy for residents' rights. And why is that? I mean, to me, there's two really main components that strengthen our argument. One, of course, is the personal. When someone or their loved one have experienced poor care, demeaning conditions, etc. And those experiences and the stories they tell are absolutely essential. But it is the data that helps to, I think, strengthen those stories and the importance of the issues that are raised with, especially with policymakers, but also with even the state departments of health and with the Centers for Medicare and Medicaid Services, the federal agency that oversees New York. We actually presented to CMS a very disturbing piece of paper that was included in a New York nursing home's residency agreement that asked the resident or their legal representative to sign off on the quote unquote fact that facts that many residents get pressure ulcers and that may happen to them. Many residents have falls and that may happen to them, et cetera, and asking them to actually literally sign off on that as part of the residency agreement. And so it's really, that was so outrageous to me. And we've raised it with CMS. And what CMS asked at the time is, do we know if other nursing homes are doing it? Well, one, what difference does it make? It's happening in this nursing home. So, I mean, I'm not privy, of course, to every nursing home's residency agreement. Um, and it's very, obviously concerning. It's something that they should be concerned about in any licensed facility and making sure that the word gets out that that is completely inappropriate and contrary to residents' rights to expect good care and quality of life services. So all these things are important. But without further ado, I'm going to talk about a few data points today. One, this is a map of the nursing home ratings in the Hudson Valley, color coded from 1 star to 5 stars, as you can see here. And so just to kind of show you, an idea of what is going on. But then in addition to a map, we have, and excuse me, we'll be posting this on our website later today, a um, a chart showing what is, the ratings for the facility. So essentially, we want people to see general map is helpful and it brings, especially if you're thinking about an area or community, or if you're talking to a legislator, it certainly has impact. But then getting down to, okay, what's actually going on in my nursing home, in my community? So I'm going to just briefly show you some of that. What that looks like. I just want to make sure yeah, I am looking at this at the right chart. So these are all, and again, we're going to post this so people can use it and share it on our Hudson Valley page. And so people will be able to see. One, you could look up your nursing home by the provider name. You could search in here pretty easily. You could also look it up by, if you wanted to search by facilities in your county. Here, you could select one or more of the counties in your area. Say you wanted to look at Dutchess County, and this gives you all the Dutchess County nursing homes. And then we go back to all the nursing homes in the Hudson Valley. And then you could also see here by what's called affiliated entity. That's the federal government's name for the chain ownership when they have identified. It's not perfect information, but it's not perfect because it's self-reported by the operators, and not all operators report completely. But you can see here, like if you were interested in a nursing home, here's Pine Valley in upstate, and it's owned by Upstate Services Group. Are there other nursing homes in the Hudson Valley that are owned by Upstate Services Group? I could just easily find out here and see this too. One is the Northeast Center, which does a lot of work with people with brain injury, and then Pine Valley, and get rid of that. Just there we go, select all again. Okay, so different ways of searching, and then the information provided. So let me search, here we are, the New York State Veterans Home at Montrose. So they now have an overall rating, I'm going to make this a little bit larger, of 3%. And again, you can, of course, find this for any nursing home. They're government owned, so you have the ownership here. So you've got whether it's a nonprofit, for-profit, or government owned. Their number, their residents, and their occupancy, which is very interesting because 80% occupancy is pretty low. Generally speaking, nursing homes need to have about 85% occupancy to be, to be breaking even. So if their occupancy is below that, that means that they could be losing money. You know what I mean? And by losing money, I mean that they are not sustaining, essentially not sustaining sufficient number of residents, because you still have to pay, of course, for heat and for, and whatever, for equipment for a building that serves, say, 250 people. And if you only have 200 residents in it, then that is costing you money. Actually, here, so we have the number of certified beds is 252, so it's pretty close. And then this page also includes the reported total nurse staffing hours per resident per day, which is 3.78, which is pretty low, frankly, and concerning. But you can see again all the staffing ratings here as well. At our last meeting 2 months ago, we provided insights into our report, which focuses on staffing. Every quarter, we do a new staffing report, and that includes not only what you see here in terms of total RN staffing, excuse me, total staffing, but also RN staffing, LPN staffing, CNA staffing, um, the amount of staff that is contract staff, and some essential non-staffing personnel like the medical director, PT, OT, etc. So hopefully we'll be able to report on that next time. We're compiling the new data, the latest data on that for the nation, excuse me, as we speak. So, but this just gives you kind of a glimpse as to what's going on in terms of the current ratings and some other relevant information about the nursing homes in the Hudson Valley. The next thing I wanted to talk, and I wanted to start off with a couple of general points. The last one and this one is looking at nursing homes in the Hudson Valley that are meeting the New York State minimum staffing requirement of 3.5 hours per resident day. That's what HPRD stands for, hours per resident day of nurse staffing time. So New York has had a law in place for several years now requiring a minimum of 3.5 hours of nursing staff time, including CNAs, LPNs, and RNs. And there's some further criteria within that I won't get into today in terms of time for RN, etc. As you may know, there was a federal rule that was promulgated under the Biden administration that also required roughly 3.5, it was actually 3.48 hours per resident day and an RN 24 hours a day every day of the year. Unfortunately, that rule, although also very low, like New York's rule, was recently withdrawn from the by the administration, excuse me, by the current administration. So we still have this rule in New York. 3.5 hours is extremely low, frankly. We had supported a rule that would be a minimum of 4.1 hours per resident day, which is the number that was identified in a landmark federal study from 2001 as the minimum necessary just to meet residents' clinical needs. Again, that's 4.1 hours per resident day was what the study found in 2001 as the minimum necessary to meet residents' clinical needs. That doesn't include care with dignity. That doesn't include providing appropriate infection control services. That just accounts for the time it takes to provide basic clinical services to residents. And what the study found was essentially the typical nursing home resident needs at least 4.1 hours. That being said, the reason why 3.5 for New York and 3.48 for the no longer existing federal rule were valuable is it brought up or would bring up some of the worst of the worst facilities. But unfortunately, as you can see here, we have do not meet desired nursing staff is blue. Orange dots are meet desired nursing staff. We have a whole lot of blue here, meaning a lot of facilities that are not even meeting that 3.5-hour staff time. And unfortunately, to our knowledge, New York State has not done anything to hold those providers accountable for utterly failing to provide decent resident care, frankly, and to comply with this very low minimum staffing standard. So again, I'll show this chart, and we're going to post it on the website as well. On this page, our nursing home, excuse me, our Hudson Valley specific page. But I want to show you, similarly to the other one, some of the information provided here. It's a little bit different, although there is some overlap. So here, the very first column is whether a facility meets the desired nurse staffing standard or does not. And again, this can be searched for by the facility name here. We include the provider number just for people's references. That's the federal number. So people can make connections if necessary, but the counties as well. So let's look at, say, let's look at Westchester County. So these are all the nursing homes in Westchester County. And so we could just have them together. There's a lot of them. And then we could select those that are meeting the desired staffing. And so we could see what those facilities are. Um, so that's one way of, and then let me just clear that so you can see. One way of looking to see, and then we also include here overall rating. And so you could actually I have a family member who's in a nursing home, and I use this kind of data to help them choose select a nursing home. And I've done this with friends as well, is that you could look to see whether they're meeting staffing standard. That's a very low threshold, frankly, but unfortunately, as we noted before, it's still very meaningful. And then I would look to see overall rating, and you could sort it from high to low or low to high if you wanted to. So these are ones that have 5 star, but some of these have 3 star, 2 star, which is very concerning. Here, unfortunately, again, the example we had before of the Vets Home at Montrose has only 3 stars, which is pretty disappointing. So again, just some, we want to there's a lot of data out there, as those of you who visit our website know. And we want to put it out in ways that are as useful as possible. But also, when you do that, when you pinpoint certain data, of course, you miss other data. So we always want to be clear, at least in what we're providing to you all, what we're providing and how. And then also, with the understanding that you can go back to our website for really full information on staffing. You can go back to our website for provider data, which includes a whole bunch of information about nursing homes, including penalties and citations, etc. So then I wanted to get into just a couple of specific data points, again, for Hudson Valley nursing homes. So the first point was about pressure ulcers. Pressure ulcers are a very serious problem for nursing home residents. According to the CDC, I don't want to just read out what's on the text here, but to me, this is really important because I'm not a clinician. I assume that most family members and residents are not clinicians also. And too often, as I said at the start, we're taught to accept things that we shouldn't. Like that facility that was telling people, oh, pressure ulcers can happen, and you should understand that, and please sign here that you do understand that. Well, that sets the tone that some bad things are going to happen, and I should accept that. But pressure ulcers, again, I quoted from the CDC here and also from a research study with people that are experts in the field, that one, they're a serious medical condition. They're one of the most important measures of the quality of clinical care in a nursing home. And that, even though some are unavoidable, for the vast majority of cases, that appropriately identifying and mitigating risk factors, meaning helping, turning residents, repositioning residents, taking other steps to address them can prevent or minimize pressure ulcer formation. So really, really important because so many, one, they're terrible in and of themselves, but they also can lead to death and they could lead to other serious injuries and problems. So the average pressure ulcer rate in Hudson Valley nursing homes is 9%. That's a little bit lower than the New York State rate of 9.6%. But New York State has always been high, which is just really terrible, frankly. When I first started 23 years ago, I remember talking to people at DOH, and they had all these reward programs for nursing homes to try to help improve pressure ulcers. They called it the war and the sore, which I thought was extremely offensive, even as someone who knew nothing about this field at the time. I was just appalled when the Department of Health person said that to me. And meanwhile, here we are. I mean, you look at the U.S. rates, which is not great. 6.5% of U.S. nursing home residents have pressure ulcers, and approximately 50% higher rates in New York State. So really, really bad. And we just have utterly failed to address this. I mean, there's no reason why 1 out of 10 or close to 1 out of 10 of our residents should have a pressure ulcer. And I should say that there have been studies now that have shown that pressure ulcer rates are very much underreported. I mean, when you think about it, and I've been a family member, my grandfather had pressure ulcers, is that it was my mother who discovered them because the facility isn't looking. They're not taking care of it, and or they're just purposefully underreporting because they don't want their numbers to look bad. So this is, by all, by, both personal experience and by what researchers said, this is an underestimation of the actual pressure ulcer rates that our residents are facing. And with this, we also are going to be providing the data on the website. And I think actually, I'm not going to go into all of them because I don't want to take up too much of our time. But you can see similar in terms of searching. Unfortunately, this data set doesn't break out the city and the county the way the other one does. But we will have it for the Hudson Valley nursing homes. There's, I think, 94 nursing homes in Hudson Valley. So still fairly easy to search and to sort by you can see the pressure ulcer rates here. This is just a snapshot of that file that we'll put on the website. Oops, sorry about that. And then the other data point I wanted to talk about was antipsychotic drugging. So for those of you who are not aware, antipsychotic drugs are very, very powerful medications. They come with a black box warning, especially for in regard, or specifically, I should say, excuse me, in regard to use of antipsychotic drugs on elderly individuals with dementia. And by black box warning, I mean black box not to use it on those people because there is a very, very high risk of stroke and heart attack and falls, Parkinsonism, which is not Parkinson's disease, but having those symptoms of shaking, etc., and that those symptoms don't go away. This is really a very big issue. We've actually, as you can see here at the bottom, New York has always here had slightly better rates than the national average, which is good, of course. However, it's still very high. And you can see the average in the Hudson Valley is higher than New York and a little bit higher than the national average of 1 out of 20. So that's very high. Antipsychotic drugs are meant to be given to, particularly for people with schizophrenia, not always for people with schizophrenia, but they are potentially appropriate. This is going to become, I'm afraid, an even bigger issue. There's been a big push by the pharmaceutical industry now to try once again to market antipsychotic drugs for elderly people with dementia. There's an effort now, especially with the Trump administration's efforts to reduce requirements and rules for healthcare and other industries. There's a big push by the industry to weaken the rules prohibiting antipsychotic drugging of residents. But it's really important to understand. Again, I'm not a clinician, but we've done a lot of work in this area over the past 13 years in particular, is that the rates of antipsychotic drugging are just ridiculous. And there was a national partnership. It may still exist, but it's been pretty dormant. That started in 2013 to improve dementia care and reduce antipsychotic drugging. And I was a part of that development with CMS. Those of you, and I know that at least Janine and Haley know Sarah, our executive assistant. We got our meeting with the head of CMS, the head of the federal agency at the time, to talk about this issue because Sarah is so nice and so persistent that she got a meeting with him. And as a result of that meeting, and they even talk about that, and we included other advocates as well, they launched this partnership to reduce antipsychotic drugging. Unfortunately, it hasn't been that successful at the time. About 25% of nursing home residents were receiving antipsychotic drugs. Now we're down to about 20%. And what we've seen, unfortunately, is that one, it hasn't gone down to the extent it should, which should really be probably like 1 or 2% of residents. But also, we've seen an uptick in a couple of things. One, in residents getting other psychopharmaceuticals that could be dangerous. And two, and New York Times did a major report on this a few years ago, that residents were being given diagnoses of schizophrenia in order to give them these drugs. And I don't want to get too much into the weeds, but essentially, if a nursing home gives a resident with schizophrenia an antipsychotic, it's not counted in their antipsychotic drugging rate. So because it's potentially a legitimate purpose. But what happened and what the Times found using our data and federal data was that the rates of diagnoses with schizophrenia of nursing home residents increased dramatically over the period from 2012 to I think it was like 2021. Well, we looked at 2012, 2021. I think they looked at more like 2017, 18. Um, and so we saw a dramatic increase in diagnoses. So I don't want to get, again, I apologize for getting a little bit in the weeds here, but I think the takeaway is to be very careful about what your resident is getting in terms of their medication. Review, don't be afraid to ask questions. I hear a lot about of providers, operators, even nurses on the floor saying they don't have time to answer questions, etc. It's good to ask questions. And we have a list on our website, and you can certainly find it elsewhere online, of what the antipsychotic drugs are, both their retail name as well as their name as a pharmaceutical. But it's a very concerning issue in terms of the number of residents. 1 out of 5 in Hudson Valley nursing homes are receiving these drugs. Again, there's that black box warning. They are not an appropriate treatment for so-called dementia-related behaviors. And that's why they come about typically is that a resident is upset or agitated, or they're making noises, or maybe they got upset and they hit somebody, and they're given these medications. And as a family member myself, I understand that you want, of course, you see your loved one agitated or upset, and someone says, "Well, we're going to help calm them down." Of course, you want to say yes. You want your loved one to be comfortable and to not be upset. But the problem is that these medications don't address the underlying reason why the resident is upset. They could be uncomfortable. They could have urinary tract infection. They could be constipated. They could have a backache. They could be upset about, bored. Or it could be that someone, approached them in a way that was upsetting or disturbing to them. So the facilities are required, and we have a lot of information in our fact sheets around this. We have a whole dementia care toolkit. Actually, we have 2 toolkits now on dementia care. That it's the responsibility of the nursing home to be identifying the underlying causes of many of these so-called behaviors and using non-pharmacological approaches to addressing them. Comfort care is something we hear about a lot in this setting. So I know I went into the weeds a little bit. I apologize for this. It's an issue close to my heart, and it's something we've really worked on. And to see that still, I just put these data together. Just looked up the latest data for this presentation this morning. It's just really striking that we've seen so little decrease, and it's really kind of it was supposed to be going down, a lot from 2013 on, and instead it went down a little bit, and then it's just kind of sat there for a while. And unfortunately, it's been hard to get either the New York State Department of Health or CMS to pay attention to it, but it's really important. The last thing I'll say on this is that there are cases in which a sedative, such as an antipsychotic drug, may be appropriate if someone is an immediate danger to themselves or others. But the standard of practice is that 2 things are supposed to happen. The 2 things I mentioned before is that one, one thing I mentioned before, excuse me, is that the facility is required to be undertaking non-pharmacological approaches, identifying the cause of what is going on and how to address it, and then doing what's called gradual dose reduction. You just put people on an antipsychotic drug and take it off, that could be very, very harmful to them. So you have to do gradual dose reduction, and facilities know this. There's a ton of trainings about this. Believe me, I mean, it's just there's just absolutely no excuse for this. But the other important thing from our perspective as consumers and loved ones of residents is that these drugs are not effective for a long period of time, even in being a sedative. So what happens is that a resident is put on, say, Haldol, and then and they're on it for a while, and then that loses its effectiveness. So then they wind up being put on Seroquel or another antipsychotic. So you have this what's called polypharmacy that just builds up. It builds up the danger. They're still not being, they're probably, the issue, the underlying cause is still not being addressed. Essentially, what you've done is you've just put a blanket over their face. You've said, you've prevented them from expressing that something bad is going on. You haven't changed the fact that something bad is going on for them. So I know it's really hard, but again, we have a lot of fact sheets that can be used to support, hands-on resident, advocacy, working with family councils, et cetera, on this, and educating policymakers, certainly, if you speak to your legislative office about this. So here is the antipsychotic drugging report. Again, we'll put this up on our website. I just want to note here, and this is true with all the data sets, as you can see, for some facilities, there's no report. Some facilities will have missing data, whether it's staffing or here antipsychotic drugging, because either the data that they reported failed integrity tests, or sometimes their data are suppressed because there are, one, integrity problems, as I mentioned a moment ago, but it also could be like if you're a special focus facility, if you're one of the worst facilities in the country, a lot of your data are suppressed just as a matter of alerting the public that there is a problem there. So there could be various reasons, but I wanted to make people aware that not every nursing home will have a data report for any of these data sets. I'm going to take, I don't know if there's any questions or comments here. Thanks for posting that, Haley. Okay, if not, I'm going to go on to the what to do when things go wrong in a nursing home. Excuse me. There we go. So importantly, as I've kind of touched on a couple times, is to know your rights, because so often we just accept things, substandard care, substandard conditions, demeaning conditions, because we have been conditioned to expect it. This is all we're going to get. I mean, I think that when it comes to nursing homes, no one really expects to have a great life there. But when we place someone in a nursing home, or when we think about the nursing homes in our community, we don't think that it's going to be bad. I mean, if we did, we wouldn't be placing people there. We wouldn't be, you wouldn't leave your loved one someplace if you thought the care was, if they were going to be demeaned, if they were going to develop pressure sores, if they were going to be drugged up, diapered when they didn't need to be diapered, etc. Other bad things that happen, and the residents' rights, the rules around that, both the federal rules and the state rules, are really strong. And the problem is that they're not enforced, but also I think to a large extent is that people don't know about them. They don't know what their rights are, and so we've been taught to accept too often substandard care and inhumane conditions. So just a sampling of some of the fact sheets we have. Virtually every fact sheet in our library is a two-pager, front and back, so easy to print out and bring into a nursing home, to bring to your legislator's office, or to share with your legislator if you're raising concerns with them, to reference if you file a complaint with the State Department of Health or the Medicaid Fraud Control Unit, which we'll talk about in a moment. All of our fact sheets, I don't think I included one here, but they all include a reference to the federal requirements, so you can easily make that reference yourself if you need to. If a facility administrator says, well, how do you know that's the rule? Or they don't believe you, you could say, well, the rule's right here. This is actually the federal code that requires that. So, we want to make that as useful to people and really appreciate and welcome people sharing those resources. So I just want to give a couple of examples here of things that I often find that people aren't aware of. For instance, all nursing home residents are entitled to receive both physical and occupational therapy services. The federal rules are very specific on that. What I hear over and over again is that residents who come in for rehab care after surgery or after stroke or something, after hospitalization, that they get therapy services. And then if they wind up needing long-term care, or if they're just in the facility for long-term care, the facility will say, that they know are no longer eligible for services. In fact, every single resident is entitled to physical and occupational therapy services. Um, Nursing homes are required to provide assistance with toileting, not just putting residents in diapers because they don't have enough staff. I remember when we were working on these fact sheets 12 years ago now, I was doing trainings with family councils in two nursing homes in New York City. And I remember talking about this issue and some of the residents getting so angry at me. I'm like, why are these people so angry at me? Um, and that's because that what I was talking about here was not their experience with their loved ones. Their loved ones were being put in a diaper as just a matter of course because there weren't enough staff in the nursing home. And so that made me, really think about it a lot. And I think, and I hope that I can share with you that to me, yes, these issues are really challenging. There's no doubt about it. And again, I'm a family member now. I've been a family member in the past. Um, and so I know how challenging they are in many ways, both with the facility and with, the individual who may be not want to make waves or not be as open to advocating or my advocating for them, etc. But if we don't know what our rights are, then you could be sure they're not going to be achieved. So at least if we know what our rights are and we have hopefully some access to materials that help support our advocacy, we can work towards getting those rights achieved. Um, and so that's why we've continued to focus on the public education, on the fact sheets, on work such as this, is because I really believe that. Again, if we don't know and we're taught to accept so little, then that's what we'll get. But I also want to recognize that these are really challenging issues. The last point here is regarding medication record review, and this is something that is fairly new, is under the rules that were promulgated under the Obama administration, which is several years ago now, but it took some time to be implemented. But every resident's medication record must be reviewed on a monthly basis by a licensed pharmacist. And any irregularities in that medication record must be reported to the attending physician and the facility's medical director and the director of nursing. And they are required to respond to that report. And in the CMS language around this requirement, CMS, again, the Federal Centers for Medicare and Medicaid Services, they specifically point out antipsychotic and psychotropic drugging as a significant potential issue in regard to irregular or inappropriate medication. So this is again a tool for families, a tool for people that are working with families to leverage, to use to identify what is going on with their residents and to help address it. So I just wanted to take you through some examples of what you can do, or scenario, not really scenarios, but more examples, excuse me, what to do and when. So essentially, consider the severity of the issue. If it's a minor care issue, it's a minor, comfort issue, then, address that with the facility staff on the floor. I hate to say start low, because facility care staff, the CNAs, provide 90% of the care that residents receive. So they're certainly not at the bottom of the totem pole, so to speak, in my view. But starting with who's closest to the resident, who's working with them directly, is always best. Rather than sometimes people will jump and go to the administrator, or they'll file a complaint with the State Department of Health. And that may not be the most effective way of addressing the issue at hand. So, again, if it's something that can potentially be handled by the direct care staff on the floor, I would go to them. And I recommend going to them. So, an example here is, if the individual's food is cold or unpalatable or inappropriate. My sister-in-law is in a nursing home now. She has diabetes. And so sometimes she gets food that's wildly inappropriate for someone with diabetes. Sometimes, people have, especially with dementia, have chewing or swallowing issues. So if you find that that's happening, then that's something, again, it's important, obviously, but that's something you could hopefully first address right there on the floor. And then, if it's a more urgent care or comfort issue, I would, go to the floor, as I know here in the second orange bullet, go to people on the floor. But if you're not getting a response, because that's sometimes they're busy, they're often understaffed. The vast majority of nursing homes are understaffed when it comes to nursing. Then escalate that concern to the supervisory nurse or to someone in the administrative staff. I mean, if your loved one, for instance, is getting, has an issue with swallowing and they're getting food that's a choking hazard, that's not something you want to let go. That has to be addressed right away. And as I know here on the right-hand side, if it's an emergency, call 911, um, and have them come in, and I don't care what the facility says. Your resident does not give up their right to emergency services because they've been admitted to a facility. And if it's a serious issue, facilities are not going to want to do that, but not going to like that. But you don't want to let emergencies, happen and someone's life potentially be at risk. So the other thing, that, and I think about this a lot, both in my personal and professional experience, is that sometimes an issue is resolved, or they say it's going to be resolved, and then it happens again, or it actually is not resolved. And this is, I think, one of the biggest issues that we have in the nursing home industry. It's one that we've studied over the years, is that, nursing home says they're going to fix their problems, but then they don't. And the problem, or they don't do so in an effective manner, so they happen over and over again. Um, so what can you do? One is that, as I said, you want to start with the staff on the floor. If that doesn't work, going to the administrator, going to senior staff, etc. Now we're just talking about within the facility. We're going to talk about beyond the facility in the forthcoming slide. Um, and so here I gave a couple examples. Mom's food is repeatedly cold or unpalatable or inappropriate for her. Again, you see someone being given, say, a peanut butter sandwich and they have swallowing problems. So you know that that can get caught in their throat. It can be difficult for them. Or in the case of my sister-in-law, that she's being given food that is high in sugar and starches, and she's a diabetic, and that could be cause serious problems for her. Um, do you find that your loved one, your dad, for here an example, is not getting the help that he needs to go to the bathroom, so he's becoming incontinent. He might be getting a UTI. He might be getting irritation or a pressure sore from being wet and sitting in a wet diaper. What do you do? Where do you go from here when those things aren't being responded? So, just very quickly, number one is you can contact your long-term care ombudsman program for help. Some of them are great. Some of them, can be a little less powerful. I think in the Hudson Valley, I'm a little biased because we run those two programs, but we have people in place that are really dedicated to helping residents and to being there and to being responsive to residents. So again, and just to be clear, if it's an emergency situation, call 911. I don't, don't call the Ombudsman program. In fact, if you do call the Ombudsman program, they'll tell you to call 911. But if it's a persistent, the issue hasn't been resolved when you've tried to resolve it within the facility, then the Ombudsman can be a powerful resource to help support your advocacy, both in dealing with the facility and if you need to, to file a complaint with the state. Um, I strongly suggest here, and I'm thankful again to Janine for her work with us when we were able to do more direct family council work, but connect with the family council in your facility or start one if the facility doesn't have one. I'll talk a little bit about more about that later on. And then raise your concerns with the appropriate department in your facility, such as going, if it's dietary services, go to the dietitian. If it's therapy services, go to the therapist. If it's medical services, go to the medical director. Um, and if there's not a medical director there or they're not responsive, that is a red flag. Because as we noted in our report in our last report 2 months ago, a lot of facilities don't have a strong medical director presence when the medical director is responsible for overseeing all the clinical care in the facility. So if you're having issues with clinical care, you should have access and get a good response from that individual. One of the things I recommended, we do recommend, excuse me, is to track your concerns. Like when I told you the story before about the residents that got mad, the family members, excuse me, that got mad at me talking about, the resident has a right to have help going to the bathroom and shouldn't be put into a diaper. And people came up to me after that, and they were really angry at me for that. And then I remember one of them said, my loved one has been having these, had issues with continence, and the facility said they were going to take care of them. And then, a month later, it was back to the same thing. And I said to her, that is a really valid problem. However, if you want a state official to address it, you're going to need more information than that. Because the state will say, if you file a complaint saying this happened months ago, they're going to want more specific information. So what we did was we put together this record keeping form for resident concerns, and we try to make it as easy as possible. And I hope you can see a date when the issue was discovered or occurred, and then what it was briefly, who was involved, or were there any witnesses, the staff person you spoke to. So if you spoke to an aide, if you spoke to the nurse on duty, if you spoke to someone in administrative or dietary, etc., what their response was and actions taken. And essentially this can just be printed out again, or so we have it as both a PDF and a Word document on our website, so people can access it in any way that is easiest for them. But so then it's an easy way. I'm not, I don't want people to feel like it's a huge burden, but at the same time, think about what a difference a complaint makes for the state surveyor, the state inspector, is the difference between you saying or right, reporting to them, we've had this problem for months and it keeps on happening again, versus we've had this problem for months. On March 17th, I spoke to Director of Nursing X, and she said it was going to be resolved. And then on April 15th, it's happened again. And when I was back on April, 22nd, it happened. It happened again and again. So you have a record there. And to me, that is so powerful. Um, and hopefully, again, we try not to make it too burdensome, because I know it's hard to be a family member. It's hard, people have lives that they're living, and in addition, they're caring for someone. It's really, really challenging. But I wanted to make it as, hopefully as easy and effective. And of course, as I think you all know, all of our resources are free to use and share. The other thing I wanted to mention, I think that this is underused, maybe for good reason. It's a fairly new requirement. I think it's about 5 or 6 years old now, is that every nursing home has to have a grievance officer. And as I know from I want to say our experience because I was, I felt such a part of the family council at Montrose that this is going to be an unfortunately very frustrating process. But what we have here, and this is an example of one of our fact sheets, is the nursing home is required to have a grievance officer. I mean, just to take a step back, a lot of these problems, nursing home problems, period, have been going on for years. Nursing homes make a lot of money off of taxpayers through Medicare and through Medicaid. And as our nation and our communities get older, there are more and more customers coming in. So it's a big business. It's a multi-billion dollar business, nursing home care. And so what the government has tried to do is to, I mean, they should be doing a much better job in oversight. And that's, essentially what, a lot of what we try to do is to improve that um, as an organization. But they've also tried to make facilities do more and be more accountable. And this is one of the ways in which they did it. Again, about 6 years ago, they required that every nursing home have a grievance officer. So if you are, think about what we've been talking, that you have an issue and you raise the issue with someone on the floor and that does work or it doesn't work, and then you're going back to square one, sometimes over and over and over again. What CMS did here is they said that you need to have a central person who is there and to whom you can report your grievances, and then it's their responsibility to take that to the to whomever is in charge of that issue. And an important part of this is that nursing home residents or the complainant, a family member, et cetera, have the right to get a response in writing. So see what CMS says is the facility does not have to do what you're asking. I mean, just because you're asking it doesn't mean that the facility has to do it. However, if it's not going to address your issue in the way you want them to, they have to provide you an explanation as to why they're not doing it. And you can request that that be in writing and get that in writing. So I think that, as I said, I saw this firsthand with the family council in Montrose that they were not getting good responses. They were getting very rote responses, if at all, to some of their grievances. I think this is something that, again, it's a fairly new rule and it's something that we need to strengthen and build up on, but the bones are there and they're good. And hopefully other facilities are doing a better job. It's also one of those things is that if you don't know about it, then it'll never be useful. So trying to make it useful there. And I think that really ties in with what I'm going to talk with resident and family councils, which I'll talk about in a minute. But I just quickly wanted to mention another really powerful tool for people is the resident assessment and care planning process and the meetings around that. Because the resident assessment, as noted here, and this is from our fact sheet, it's required, excuse me, that the assessment include a lot of different issues, not just basic clinical care, but resident goals, their psychological well-being, their customary routines as individuals, their background and demographic information, their activity pursuits, skin condition, of course, which we've been talking about, dental, which we've been talking about, etc. So just an important resource and tool for you to use because you can ask for a new assessment or care planning meeting. There has to be a comprehensive assessment on at least an annual basis, and then shorter assessments on a quarterly basis at least. Um, and again, you can call for these things and use these resources to stick to your guns. Because I've been in care planning meetings where they want to make it like 5 or 10 minutes and they're directing the whole thing and blah, 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 out the door. Um, and no, so you have, this provides again a foundation for one to prepare, and two to stop them and to say, no, this is this is what, what we're entitled to. So I think it's in many ways a really good starting point. But I wanted to spend a little bit of time talking about resident family councils. I, as I mentioned, I've had family members that have been in nursing homes. I have not had family members who have been very active in their resident or family council, and that's a shame because I think that they can be enormously powerful. And I remember when my godmother's mother was in a nursing home, and I visited her pretty often. We were close, and I suggested because it was not a good nursing home. It was on Long Island, joining the family council, and she like just didn't feel like she had time or was worth it. This was many years ago now, um, and what I've seen from the work that we've done and the reasons for that work, the research behind um, the value of resident and family councils is, as I note here, one, there's strength in numbers. All these things that we're talking about, including, pretty much all of them, but, from the basic grievances about food issues, about toileting and staffing issues, to the grievance officer and the effectiveness of the grievance officer, having a resident or family council that can speak as a group provides an enormous amount of strength and weight for the facility, and both in the facility and outside of it, if you go to speak to one of your legislators. I think also, as I know here in the second bullet, there's anonymity in numbers. Is that if a lot of people are afraid, and sometimes rightfully so, of repercussions if they complain. But if you're doing it as a family or a resident council, you're doing it as a council and not as an individual. And don't let them bully you into saying, who's the one who has the problem. Because believe me, if one person has a problem, then it's almost certain that everyone has the problem. And I think that it makes it, in fact, easier rather than harder to handle complaints. One, there's just I think people underestimate the value of having compatriots and companionship and the experiences that you have, but also is that you're not just handling this on your own against this behemoth of a facility. Is that you have the other family members or the other residents there who can be part of it. So a couple quick tips. I know we're coming up to an hour, but I just wanted to mention, invite facility staff at your discretion. Too often I hear that facility staff are running these meetings and taking the notes for these meetings. Wherever ever possible, that should not happen. Certainly not with family councils. I know sometimes resident councils may have less ability, individuals may have less ability to take notes, etc. But please be very careful about that because the people who write the notes at a meeting, any kind of meeting, are the ones who control the narrative. And too often facilities will try to co-opt the resident or family council. Second, I recommend meeting with the surveyors. Surveyors have to talk to the resident and family council. Um, they're expected to, excuse me. So, when there's a survey, when there's an inspection of your facility, make sure that a representative, if not, more people are there to meet with them. Invite your long-term care ombudsperson and invite your local legislator and or their staff to attend those meetings because that can be really powerful too. A lot of times all they hear from is from the providers unless we are there talking to them. And this gives them an idea of what is going on. So here's some of our resources, and I'll shout out Jeanine again, who was and Haley, of course, who are both instrumental in putting these resources together. And then just very quickly, going beyond the facility, we have a whole abuse, neglect, and crime reporting web center on our website. You can see on the lower left-hand side. But if it's not working in the facility and it's not working with the ombudsman helping you in the facility, you can file a complaint with New York State Department of Health and or the Medicaid Fraud Control Unit. Every state has a Medicaid Fraud Control Unit. Ours is in the Attorney General's office. We have the contact information for all of them on this webpage. But the Medicaid Fraud Control Unit has as its mission going after abuse and neglect in nursing homes. And to me, They are making the biggest difference in New York in terms of going after providers. As I mentioned a number of times, contact your state or federal legislator, your member of Congress, your state excuse me, your state senator or our senators in Congress. Um, they can be responsive. They can be very responsive, actually, and it's really important for them to hear. You can contact the CMS location or regional office that oversees the Department of Health. Again, we have the contact information here. So if you're not getting a good response from the Department of Health, you can go to them. And then lastly, we recommend seeking legal assistance. If you have, a case of in which your resident or family member has been abused, has been neglected, if they've died as a result of poor care, um, it's one important way to hold nursing homes accountable and to make things better for the next residents. Because that's really the only way that a lot of operators learn, if they do it all, is when it pinches them in the pocket. Frankly, the New York State does not give out a lot of fines or penalties. They tend to be very low. So a legal decision or a decision from the state Medicaid fraud control unit can, or, excuse me, a court case from the state Medicaid fraud control unit can be in the millions of dollars and can make a real difference. Here's just some resources on our website, including the forums I spoke about. And of course, we have our Hudson Valley page up here where all these resources are, although we're going to update that today with these resources I mentioned earlier and our other resources at nursinghome411.org. Our next program will be on February. Oh, I didn't give the date. Was it? Sorry about that. I'll fix that. But is it 20th? Am I
I
remembering
have
right?
to I have to double check.
Thanks, Sally. Sorry about that. But you'll get an invite if you're part of our email server. Anyways, my mistake. And the residents' rights focus will be on discharge protections and also access to services. I was thinking that I want to talk more about how people have the right to therapy services and people, no matter who's paying for their care, whether they're long-term care or short-term care, and other services in the nursing home, as well as transfer and discharge. We hear a lot about discharge problems in New York nursing homes, including in the Hudson Valley. I wish you all a very happy and healthy holiday season. Thank you for joining us. And
February
February
19th.
19th, I was close. Thank you.
Yes.
February 19th is our next program. Thank you, Haley, and we'll correct that. Thanks so much, and nice to see you, Janine. Thank you, Donna, Jane, Linky, and
What you do is
Maureen.
invaluable. Thank you for doing
Oh,
everything you
thanks,
do.
Janine. I
Thank
really
you.
appreciate that. Thank you. Bye bye now.
Thank you all.
Happy
Happy
Christmas.
holidays.
Yes.